Welcome to today's OBSSR Directors Webinar. I'm Jane Simoni. I'm the Director of the Office here of Behavioral and Social Sciences Research at the National Institutes of Health. And before I introduce today's speaker, I just have a few housekeeping items. First, today's webinar is being recorded. The recording will be posted on OBSSR's website in about a month. Today's presentation will be followed by a Q&A session. To ask a question or comment, use the Q&A button at the bottom of your Zoom screen. Feel free to ask questions at any time during the webinar. Please note that the chat feature is disabled and all attendees will be muted during the webinar. Following the presentation, Dr. Michael Spittle, a health science administrator here in the OBSSR office, will facilitate the Q&A session. Now I'm pleased to introduce today's speaker, Dr. Rebecca Wong. Dr. Wong is a professor at the University of Texas Health Science Center at San Antonio. Her research focuses on the social and economic consequences of population aging, particularly in Mexico and among immigrant Hispanics in the United States. She serves as the principal investigator of the Mexican Health and Aging Study, a 20-plus year longitudinal study examining health dynamics in a broad socioeconomic context. She has contributed to the editorial boards of several publications and has served on scientific committees for the U.S. National Academy of Sciences and the Advisory Council for the National Institute of Child and Human Development. And sorry, turn off my phone. In 2024, Dr. Wong was elected as an honorary member of the National Academy of Medicine of Mexico. This webinar also is the inaugural Norman B. Anderson Memorial Lecture. Dr. Anderson, the first director of OBSSR, was a pioneering figure in behavior and social sciences research. His research focused on the intersection of health and behavior with a particular emphasis on addressing racial, ethnic, and socioeconomic health disparities. It's my privilege and our honor to dedicate each of the spring directors webinars for the coming, from now on, to Dr. Anderson. In recognition of his profound impact on behavioral and social sciences research, we will be proud to host these to honor his legacy. And now, Dr. Wong.
Thank you very much, Dr. Simoni. I appreciate the introduction and, of course, the invitation. I had not heard that it was the inaugural, and so it's wonderful. What an honor and privilege to be able to speak. In particular, because OBSSR has such a cross-cutting influence on all of the NIH. So this is a very important office in the NIH. I appreciate, like I said, the invitation, and I decided to talk about the fabric of aging in Mexico and give you some ideas of patterns and the potential that I see as a result of my work in the last 20 years. So what I would like to do is to first start with a motivation to study aging of Mexico, and then the evolution of the study that I will be using a lot of the results to be making some of the points. And I chose to highlight several points around a select research agenda. Those would be the patterns. And then I will talk about the conclusion and in those patterns and the potential for the future, as well as the present needs that I see for advancing further. First, the motivation for studying aging in Mexico. This is not new. These are points that are singled out very often when you hear about aging outside of the United States or outside of developed countries. The speed of aging in Mexico was much faster than what the previous countries experienced, the high-income countries. And this is just a result of having had a very fast demographic transition with mortality and fertility declined. And so aging ensued. Again, also aging occurs with low and social economic development and with low support for old age, institutional support for old age. There were fast changes also in condition of older adults who survive. The current elderly that are older adults in countries like Mexico survive high levels of infectious diseases, which is a common feature of aging in, like I said, low and middle income countries. And at the same time, chronic diseases is a growing problem and will affect them in their old age, yet infection diseases are still prominent. And so, and there was one particular item that is very unique to Mexico, which is that the well-being of older adults in Mexico is closely and persistently linked to the United States. With that in mind, then just to illustrate, the proportion of the population that are 65 years and older in Mexico was about 6% in 2010, and it will reach 15% in 2036. It will take about 26 years to do this. Compared to other countries, and this is the example that we often cite, the US took 69 years to go through the same transition and achieve 15% in 2013. Compared to France, who took 115 years to go from 6% to 15%, and they achieved that in 1980. So it's what we call an accelerated aging that scholars in the 1990s and early 2000s started to talk about. The gains in sociodemographic conditions happened also fast. There was a trend of increased education in the population that started to survive. And so, for example, if you take cohorts who are 50 to 59 in Mexico, the percent that had less than 5 years of education used to be 61% in the year 2000, circa 2000, and now is about 25%. So it went, in the improvement in education was really, really fast. The mean number of children also went down really fast. Population age 50 to 59, those who are entering middle old age, the fertility number of children they had went from 5.1 in the year 2000 to 3.3 in 2018. These are, again, really fast changes that happen. And these are common to many countries, in particular in Latin America, just because of the timing of the demographic transition in the world. And like I said, one of the other points was that Mexico's aging is closely linked to the US. It's simply the proportion of males that are age 60 and older in Mexico. Currently, about 16% were former migrants to the US in the year 2000, and about 29% had at least one child who lived in the US. And that establishes that there's a large network of migrants, but also of migration and of the children that sets a codependence for old age between the two countries. And so this, in brief, justified the evolution, the startup of a Mexican health and aging study, and then I'm going to talk to you a little bit about how it evolved. So we started thinking, and before the seminar, we were talking about our colleague Alberto Palloni. In the 90s, Alberto Palloni and Beth Soldo and I were starting to talk about starting a study of aging because all these points that I said justified this prospective national longitudinal study of aging in Mexico. We put a group together and talked about starting a study that would be comparable to the US Health and Retirement Study. We would follow adults age 50 and older until death. There will be an exit interview after death. Couples will be followed in trying to understand the life aging as a couple, but also widowhood once one of them died. And that there will be an oversample of migrants who at some point, now in Mexico, but at some point were migrants to the United States. Again, to study this, the consequences of migration in old age. Just fast forward, and we're looking at a study that we started in 2001, and just briefly, I'm not going to say much about it, but we are funded to conduct the study every 3 years, and then we add new sample every 6, and we are funded to do 2024 and 2027 right now. And also, as it evolved, the study, then we added ancillary studies for dementia. In the bottom, you can see that we use subsamples of the core study and to try to get to other specialized topics, such as the prevalence of dementia in the world. And this is all harmonized with the Health and Retirement Study and other studies in the world that I'll mention later. Now, I'd like to highlight a few items or results, patterns around a selected research agenda. And I selected these 4 points or topics. I'd like to talk about the Mexican migrants to the U.S. that then now have returned to Mexico. And then I would like to offer some insights from rural populations in Mexico, what we have learned about aging. Then I'd like to talk about the role of the family for old age support, and then the health of subsequent cohorts, or how the future of aging looks for countries like Mexico. In all of this, even though I said countries like Mexico, because we really see many countries at the same stage of the, like I said, the demographic transition, and so many countries will undergo similar aging patterns. So the first point was that I would like to highlight the Mexican migrants to the United States. So they are now, like I said, older adults who are back in Mexico. And we see then, when we analyze that, we see persistent patterns of codependence between the two countries. So I will illustrate that point. And then I also will talk about the conditions of those who stay in the United States and those who return, which is one of the major motivators, like I said, to start this longitudinal study. So we see migrants, whoever migrated, Mexicans, whoever migrated into the United States. And we wanted to, in this particular slide, we're comparing people who are 50 to 59 in 2 different times, in 2001 and 2018. And we leave them at 50 to 59, the ones entering old age, again, middle and old age by gender. So when we see this, these are men in the left, women on the right in green. And we see that in 2001, about 20% of men aged 50 to 59 in 2018 were former migrants to the US, and now they're back in Mexico. And that went up from 11% to 20% in 17 years. And among women, it's much lower, but it went up from 2 to about 4.5%. So the migration to the US is part of the lived experience of a large representative portion of Mexicans, in particular men. And so that means men and their families. The prevalence has increased over time for both men and women. And this increase is similar if we don't take it as total, we take it in rural and or urban areas also increased. It increased more in rural, but it increased both in urban and rural. And if we take all people ages 50 and older, and not just the ones entering middle age. What is of interest to us is that this has continued to increase despite the tighter policies in the border, or in the ability of the people to get jobs throughout the, say, for example, the recession of 2008, in which the migration to the US from Mexico contracted a lot, but this continued to be a flow that we see pretty consistent. Now, again, the other point is that there are older adults in Mexico who have children in the US, even if they were not migrants themselves, they have children in the US, and that proportion used to be approximately 27% in the year 2001, and now it's about 20%. It's about 1 in 5 older adults age 50 and over in Mexico who have at least one adult child who lives or works in the United States. And that just means that it's a high, again, supporting the point, it's a high codependence between the two countries in old age as well. The pattern has persisted, like I said, despite those stricter border measures and other economic up and down in both countries, Mexico or the US, these patterns persist. And there are also very stable patterns of age at first migration and at last return. Here we see in the population in 50 and over, whoever migrated to the US in 2001, the median age of when they leave is around age 20, 25. And then also how long they stayed after they report their last return. How long did you stay? And on average, they stay of 6 years, and then reported about 5 or 6 years. And that's sort of stable patterns. This particular piece of work compares among survivors, the Mexican migrants that went to the US and are still in the US at age 50 or older, and those who return to Mexico, either they return after age 50 or before age 50. So you see this set of bars, these are just 4 models because they increasingly control for more covariates, but the result is the same. The darkest bar is the probability of those who remain in the US past age 50, and the probability of having ADL limitations. ADL is the activities of daily living, so they are basically reporting a disability. And so the gray area are those who are back in Mexico and return before age 50, and the lightest is those who are back in Mexico but return after age 60. They're already back. And so in general, so the result is that Mexican immigrants who remain in the US past this age 50 are more disabled compared to those who return to Mexico, and it doesn't matter what age of return we compare them with. The disadvantage of immigrants staying in the US persists even after you adjust for demographic, childhood, and adult characteristics. This author who did this work did a pretty good job at contrasting and comparing and controlling, but it is true only for survivors. It's not looking at selection for survival. So this excludes those who die. And these people are found in the US alive. These people are found in Mexico alive, and those are the ones that are being compared here. And the next point I'd like to highlight is what is the condition of rural populations in Mexico in comparison to urban. And so it's for us, having a rural representative sample of older adults, does it offer new insights of what we can learn about aging? So first, this particular work presents the cognitive function score for urban dweller people and rural dweller people, but it's over the life course. People who live urban, early life and late life, rural, urban, early rural, late urban, and people who consistently live in rural in childhood and rural later in life. And so we see here are the different cognitive domains, and we see that the rural, those who were living persistently or consistently in rural areas have lower cognitive scores than those who had more of the life course exposed in urban areas, and this is the ones who were mixed. And we obtained similar results with this work so that in different domains of cognition, you see the same pattern. So that across cognitive domains, cognitive function is higher if you were exposed longer in your life to urban dwelling compared to those who are in rural dwellings. And that just means that for countries like Mexico, rural residents, it's similar to, the most pressing or clear marker of health disparities. And so this is a very clear health disparity for us because it talks about exposure over the life course exposed in rural areas with respect to education, employment opportunities, access to healthcare, and so on. So this is talking about cumulative disadvantages of the rural areas. Another possibility that we were curious about, and this is unpublished work, preliminary results for Miguel Arce Renteria, was looking at bilingual language, people who speak 2 languages, and whether it offers an advantage for cognition. And so this body of knowledge has documented that even though it's mixed and not particularly absolute, in general, in high-income countries, people who speak more than 1 language have a cognition advantage. And so you can hear in the popular press, if you go ahead and start learning a language, that would give you some cognitive engagement, and it will provide some cognitive reserve. And so we were curious in this group is working on looking at the bilingual advantage that you can see in Mexico in both urban and rural areas. we find they find no bilingual language. These are the urban areas, and these are people who speak Spanish and English, and they offer no advantage with respect to having a better cognition in if you are a bilingual versus not. And then, but the interesting result is the next set of bars, which is going to show the rural areas. And the rural areas, what it shows is that those who are bilingual actually perform worse compared to monolinguals. Of course, suggesting that we have a lot more work to do here. We don't know if it's really that it's an indigenous language, and that's why it doesn't offer an advantage, because we are conducting interviews and we are conducting cognitive tests in Spanish. And whether this means that the fact that they speak both, maybe they speak one much better than the other, or if it's indeed some disadvantage that the fact that they're indigenous populations offer some cumulative disadvantage that we are not capturing over here. And so these are very interesting work that offers this insight for us that we really need to think more about what we're measuring in rural populations, or in countries in which their disparities are such that the disadvantage or understudied populations are completely different in many of the hypotheses that we are testing in high-income countries. And this is in contrast, like I said, to what you can find in many high-income countries. For example, this work by these authors on the contrast of bilingual Hispanics in the United States. Those who use dual language more in their daily life was associated with higher, these are mini-mental standard scores for cognition. And it's associated with a higher cognition score, but not with a change in the cognition score among Mexican Americans in the US, age 65 and older. So that means that we observe a little bit more of an action of dual language among those who are in the US. And then future work, as these authors state, should characterize bilingualism with greater nuance. For example, when did you learn it? How well do you speak it? How often do you practice it? And so on and so forth. And also with more rigorous cognitive measures to identify the components of these bilingual pattern that may benefit the cognition of older adults who are bilingual. Now I'm going to turn to the role of family support. One of the major hypotheses that is offered or research questions when we talk about aging in low middle income countries is what is going to happen to the support from family, which is the anchor of the help that older adults get, as I said, because in many countries, the institutional support is very limited, or many older adults don't have access to it. So with the role, many scholars express concern that as older people have fewer children, does that mean that they will have less family support from the family? And so would the role of the family be eroding as fertility continued to go down? And indeed, this particular work shows that the economic help that older adults were receiving was significantly reduced. They looked at a decade from 2001 to 2012, and they show that the financial help declined over time. If you look at these are non-family income is in blue, whereas family income economic help is in orange. And you can see from 2001 to 2012, among those in the highest income brackets, and that's why you can see them better, the percentage went down, but it went down in every one of the income quartiles. And so in essence, this is the total, indeed, family help went down, both in the prevalence of people who were receiving it, but also the amount that they were receiving. This paper in particular, I liked it a lot because it talks about whether there was a reduction in the caregiving that was received among older adults in Mexico but it tries to test whether part of the reason of this for this decline, or part of this pattern of decline of health, is due to having fewer children, or is it because you don't need the help? Maybe you don't get as much help because you're less sick. And so in this particular paper, they take adults aged 60 to 76 in the year 2018 and compared to what happened in the same age brackets, age 60 to 76 in the year 2001. And they look at how many of them have one or more activity of daily living limitations, such as bathing or eating. And so they look at how the parents were, and how the parents were in 2001 compared to 2018. And so what you see here in blue is in orange is the pattern of having difficulty. And so compared 2001 to 2018, those who are in 2018 are more likely to have at least one limitation. So they are more disabled in 2018 than they were in 2001. On the other hand, this is how likely they are to receive help, given that they have an ADL limitation and they receive less help, which is consistent with the previous slide that showed that the financial help went down, economic help went down, but this is hours of caregiving support, and it also went down. And so this is what happened in that, again, when you compare these two cohorts. And so the question is, why? And so what this paper does is compare whether they compose the change, and they look at whether the number of living children that they had went down, and that's why they received less help, and how much is correlated with this change, or if that is because they are less sick and they need less help. And so they attribute, or they find that the lower number of living children and the percentage of cognitive impairment explain a small percent number of children and a higher percent in cognitive impairment, the decline or the improvement in cognitive impairment among people who had at least one disability was attributed with 44% of that change. So indeed, there was a decline, but it's not due to having fewer children. It's more due to having less of a need for help. And then the next point is that I'd like to highlight is what happened to subsequent cohorts as we are thinking about the future of aging in these cohorts of Mexicans. Are subsequent cohorts of survivors increasingly more or less healthy? How do they look? Do they look more or less disabled? And how are future older adults in the short and the medium term in other conditions? So what we see is, this is work with Colin Payne, who did work of active life expectancy. So he took different cohorts born in 42 to 51 compared to the cohort born in 53, 62. And let's just stay here and say, when they are 50 to 59, what is the life expectancy of this cohort? And what is the life expectancy without disability of this cohorts? And then you see that if they're going to be active, 61% of their expected remaining life, they're going to be physically limited, 35% of the remaining life, and they're going to be disabled, 4% of the total remaining life. And so what you see is that if we compare then a more recent cohort, say those born 53 to 62, when they were the same age, 50 to 59, and they see that this group is going to spend a larger fraction of their expected life expectancy with physical limitation or with ADL disabled. And so the cohorts, the more recent cohorts, are going to face more disability over the remaining life. And the same is true if you take the cohorts when they were born here, but taking when they are 60 to 69, their remaining life is going to be also more disabled among the more recent cohorts. The same thing when they're 70 to 79, they're going to be more disabled. And so, in other words, we see an expansion of disability. Successive, younger, more recent cohorts will spend more fraction of their lives with disability. And this is the same, except that women are on the left, men are on the right. And just quickly, you can see that women will spend a larger fraction because these bars are larger than these. These gray and black shares are larger for women than for men. So women are expected to spend a larger fraction of the middle and old age in disability compared to men. And then by looking at another pattern, we were looking at the cognitive function over the 14-year period over time. So we can see that they become less or more cognitive in functional in cognition with respect to, again, comparing between 2001 and 2015. And why are we thinking that they could be better functional? And that is because we saw that these are more educated cohorts. They had higher access to healthcare and they had higher education. So when that happens, that the question is, would we see an improvement in cognitive function? Because education is so highly correlated with cognition and access to healthcare as well. So if we saw these two things in between 2001 and 2015, would we see better cognition? However, we see higher cardiovascular disease risks, and that's the issue. And behind this, that not everything was in good shape, but many of the chronic diseases got worse. And so what we see is a lower risk of mild cognitive impairment, but a higher risk of dementia. So we're not able to say that thanks to these things that improved in Mexico, in this population, that we are able to see a decline in dementia, which is what we have seen in the United States. So the improvements in educational attainment that happen in this society and the improvement in treatment of diabetes and hypertension happen, and also they had better access to healthcare by 2015. But that, we think, just wasn't enough for us to observe the combined effects of aging and rural residents' disadvantage and this higher risk of cardiovascular disease. And so we're not able to see an improvement in the risk of dementia. And this is the one trend that I wanted to show. With the growing prevalence of obesity, then everything else that we are saying, an increase in cardiovascular diseases and conditions just were not favorable to these cohorts, even though they had higher education, better access to healthcare, fewer children, and so on. The rising trend of obesity just kept increasing. And so for female in particular, it's higher always than for males. And so that trend is just not allowing the gains to capitalize for all the cohorts. And then we are, this is a paper that was produced a few years ago, and when there was a future elderly model was used to project what would be the future prevalence of diabetes. And when you observe these three longitudinal cohorts and follow up, then we did a projection of the prevalence of diabetes. If there was no intervention and every condition stayed the same, this is a model that uses many equations of chronic conditions and obesity in childhood and so on to predict what would be the prevalence of diabetes. And so the no intervention scenario showed that the prevalence of diabetes would be going from 19% to 34% in 2050 among those who are age 50 plus. And indeed, we just looked recently and said, how did we do? And if we are in 2021, how did we hit? And indeed, the prediction was pretty good, was very close to the no intervention scenario. And so we're able to say that if we do use these longitudinal data to do prediction models, we can also predict what would happen in if there were some interventions to reduce the say reduction of sodium or some other medication for diabetes were introduced and so on. So I wanted to conclude about these points that we kind of went through just now. So the key points that we highlighted was that there were permanent links between Mexico and the US. These codependence persists, and it doesn't pretty much matter what is the status of the economy or migration policies. There's a persistent dependence between the two countries and extends for old age. There is, I think, a major benefit from looking at rural-urban differences. In particular, rural population patterns may provide new insights on aging of the population. And this was not something that we were expecting to see, but it happened. The family support for old age may be reduced, but apparently not just for reasons other than, it seems to be for reasons other than having fewer children, much more powerful than the number of children. So this prediction that everything would be not good when you have fewer children with respect to family support, it doesn't seem to be happening. And of course, we do see an expansion of disability and chronic diseases in future cohorts that are entering middle age. And this seems imminent as demographers. We can also already see who is born, who's alive, and we already see trends that are not very favorable to those who are entering middle age in the future. I wanted to just highlight then next some potential for more research. And then just say that when we have these longitudinal cohorts, as many of you know, we are able to show and analyze the effect of structural reforms or cancellation of social programs, and indeed the effects of COVID, because we have these longitudinal cohort and the different cohorts that are entering middle and old age. This, for example, shows that mental health was going down for these are the cohorts in the year 2012, 15, 18, and we took 21 in the number of depressive symptoms. The prevalence, if you saw it all total, would be declining among older adults, except then if you separate those who had a COVID-19 major event versus none, and you compare 18 versus 21, and indeed the mental health worsened among those who suffered a COVID event once separated with respect to loneliness as well. And so this is something that we will continue to look and follow over time and see whether these cohorts recover and to what pace and who recovers better than others. The other thing I wanted to highlight is that this kind of studies, the longitudinal studies have mushroom multiplied in the last 20 years. The longitudinal national studies that are similar to the HRS, the Mexican study was the first one that was similar to Mexico, and we have the longest follow-up after the US. But the study in England and in Europe, this is 20 countries, and Ireland and China and India, and they have multiplied. We have an empty space in Latin America and in South America and also in Africa, but we hope that this is the kind of, by showing the kind of work that we can obtain and we can do with these cohorts, that more and more countries will become available with this kind of data. Just to mention two components of the evolution, the study, just like the US Health and Retirement Study, has become very evolved. It has changed quite a bit, but one of the major things that I see is that it became a lot more important for perceptions, for psychosocial aspects like loneliness, like you said, like you saw, and life satisfaction in those psychosocial aspects and behaviors, personality traits. We started measuring more of that than the traditional demographic surveys of health and health behaviors. And also we started to measure performance as well as markers, blood, saliva, hair samples. These all became very prevalent in Mexico as well as the other countries, as much more prevalent, of course, in the rich countries because of budget. but also we also add a lot of the historical context of the longitudinal cohort by adding, just like in the US, the aspects of social policies and now exposome and environmental data. And of course, this is just to show that we started in 2012 to gather data on genetic biomarkers. So now, because of the longitudinal follow-up of the social and behavioral aspects, which is what they call the phenotype, we combine them with the genotype, the genetic biomarkers, and then we can potentially contribute significantly to studying health disparities. And now I'd like to reflect a little bit of opportunities for behavioral and social scientists to contribute to health disparities. I think that these long representative panels facilitate our study of social, economic, and health resilience. I think the resilience in examining who bounces back better, as I was saying, who recovers better, and what aging patterns these people have would offer a lot of lessons. And we can do it because now we have the long panels. The rich climate change data that is available, it's out there in the clouds and in NASA and in all their agencies that gather climate change data. Now we are combining them with the long panel of individual and households surveys. Then we're gonna have a lot more studies of environmental exposures over the life course. And then we, as I said, we can combine biomarkers and social data, which will support studies of how the environment affects the gene activity. And so these are the epigenetic studies that I think would be very, very useful, in particular, like I said, in rural versus urban areas. And age continues to be the most powerful risk factor of disease, right? And just about every disease that you hear about, in particular, dementia, or cancer, age is the most powerful risk factor of disease and mortality. And now we can study it with biological, social, and economic perspectives. So these are things that I think that can see that I see where the opportunities are opening for this kind of studies. And now I'd just like to close with the pressing needs for advancing further. Just one more slide. And I went with 3 different things. I think that we need more people who will get out of the comfortable disciplinary zones. We have a lot of people studying life course from the social perspective, even economic, but we need to combine it with the biological and environmental exposures. We have people who study mixed methods, but we need more people who study this long follow-up of cohorts with qualitative studies as well. And I think that we need to look at more solutions, not just in public policy, but also in private. The combination of private sector solutions with the public institutional solutions is probably going to be the way to go, because in low middle income countries, the private sector for provision of social and health services is pretty large. And so we need to think, of course, we think of the family, but I think we need to think also as the private sector itself. For capacity building, I think this is pretty obvious. We don't have as many scholars in low middle income countries where all this data come from that are able to use the data like we use it. And so being able to mentor people in low middle income countries, partnering with them and learning from them is, I think, something that will increase all our capacity as to working jointly. And then these are methods that are not new. I just wanted to highlight that we need to continue progress on these areas, looking at longitudinal data analysis with the life course perspective. But I really want people to think about how to integrate different methods, different data, looking at data from childhood and data from adolescent life and from old age. We obviously I've just presented data from middle and old age, but it would be very powerful if we had more data that brings together different aspects or different stages of the life course. We do have reports of childhood, but they are retrospective results from the same individuals. And it would be very, very powerful, I think, if we could put together data that is available in low middle income countries from other age cohorts. And I think more people need to think about survival and attrition selection when I reported some work from scholars that don't particularly correct for selection. And so I kept talking about the survivors, those who survive, and these are the patterns. So we need to just think about that. And then I think that the approaches for doing cross-national and cross-groups research are very, very proliferating now more, but they are not as developed as they could be or as used as they could be. And so learning more between cross-groups, like what I was saying, comparing the life course of rural areas versus urban area residents, and how formally to compare those life courses pathways, I think would be a very good way for us to make an advanced methodological. And I just want to acknowledge people. I cited a lot of these people's work, so I wanted to acknowledge that, and also my team who helped me with the preparation of the presentation. And this is the knowledge of funding from Mexico and from the US. Thank you very much, and I look forward to questions.
Thank you so much, Dr. Wong, for that excellent presentation. We received a lot of questions from the audience. I won't be able to get to all of them, but I'll share many of the questions as I can. As a reminder, you can submit your questions or comments using the Q&A function at the bottom of your screen. So first, a question, the proof that disability actually is more prevalent with stayers, is that evidence of no salmon bias effect? In other words, the healthiest are not going, are going, right?
Right.
The more disabled
Yes.
are staying. So is that?
Yes, the authors of this work stated that way, saying that because stayers seem more disabled than those who are observed back in Mexico, it looks as if that contradicts the salmon bias effect. People are not going back because they are less healthy. However, I wanted to qualify that because this is survivors. Right. And so it's possible that those who were in worse shape went back and died, and we don't see them.
Right.
Related. So that needs to be taken into account when we say that the stayers seem less able.
Excellent. Thank you. Related to the disability questions, there are a few other types. I'll go over them. Question: is there information about the type of disability found among those who stay in the U.S.? And is there a comparison of health outcomes between older adult Mexico living in urban versus rural places in the USA? Like the comparison group being matched to US.
Yes. I'm going to start with the second one. I think that no, we don't have enough representative samples of rural populations in the US, in particular of if they are migrants, right? But no, in general, I think we need more work on rural populations. And that's one of the reasons why I focus so much on rural in Mexico, to say we can learn something for a lot from looking at the disparities in the two groups that are so different. And so the same thing in the US. I suspect that there's a lot in rural US that is not as general, the results are not as generalized as we think they are, but we just don't have enough samples. And then the first question was, do we know enough about what kind of disability? We could, and I'm sorry, I cannot differentiate right now what kind, but yes, that particular paper used HRS and MHAS and compared, and we know that both surveys have the type of disability they have. And I cannot tell you that, but it's possible to compare that.
Thank you. A few other questions relating to the language in the bilingual part of your discussion. One, is the bilingual analysis results independent of education and SES?
Yes, they're controlling for, yes.
Okay, the next one is, For the influence of bilingual ability on cognitive function, have you looked at the influence of Spanish versus English as the preferred language or proficiency in the second language? How did you operationalize the language question?
In that particular work that I presented, the authors just use the question, do you speak? Do you speak? And so that's one of the comments that they make, both in those two papers I presented. The comments they make is that we need to capture more the nuance of this language. How did you learn it? What age were you when you learned it? How do you use it? How often do you use it? And so on. That is probably going to open more the results that we're looking at, probably not showing enough results because we're not controlling for that or taking that into account. And so indeed, in the next wave of the Mexican Health and Aging Study, which is this year, we are adding language questions such as those. When did you acquire it? How often do you use it? How proficient do you think you are?
Great, thank you. Related to the cognitive tests, a question came in, how much the performance of rural populations on cognitive tests correlates with disabilities or comorbidities that may signal accelerated aging?
Yes, I can't remember if this particular work that I showed is controlling for chronic conditions. It is possible, but not necessarily. And so, yes, we could potentially examine the comorbidity correlated with the cognitive function. In many other papers, they do control for aspects such as time use, social engagement, in addition to education, and also physical exercise and chronic conditions and depressions and so on, but others don't. And so I can't tell you, but yes, it is possible to do that. And yes, in many cases, cognitive function is correlated with physical function and chronic diseases as well.
Thank you. Last set of questions related to dementia. Is the incidence or prevalence of dementia higher in Mexico as compared to the US, age standardized? Question one. Question two, did you say that only a subset of the MHAS participants were followed for dementia age-related studies? Who are in this subgroup and how were they selected?
Okay. So the first question, okay, now I already forgot the first question.
Is the incidence or prevalence of dementia
yes,
higher
the
in
US.
Mexico?
Yes.
Yeah.
Yes, indeed. The prevalence is higher in Mexico than in the US. The prevalence of cognitive impairment and dementia is higher, age adjusted. And of course, there are many reasons for this difference, right? Education and again, comorbidities and so on. If you adjust for those, still, if you look at the two curves, the prevalence of cognition in Mexico is above the prevalence of cognition in the US. And then the second question you had was...
Did you say that only a subset of the MHAS participants were followed for dementia or age-related studies? Who
yes,
are in the subset?
So from the beginning of the MHAS, which is a national sample of about 15,000 people, and we refresh sample every 6 years to have about 15,000 all the time. From the beginning, it has had a cognitive function battery of about 12 minutes, 12 to 15 minutes it lasts. But these subsamples that we took for the ancillary studies were smaller. So instead of the 15,000, we have about 2,600. Now the subsample is about 4,000. And so we're funded to do a third wave of that. And it's going to be about 4,000 of a subsample of 4,000. But that's a detailed cognitive battery that lasts about 60 minutes. Mm-hmm. And so that's the one that is a richer, it's called the Harmonized Cognitive Aging Protocol that's being applied in several countries of the world. And we are one of them, and the US is one of them, England and so on. But but it's a much more detailed battery of cognition. So you can have the larger sample of the core survey with a shorter battery of cognition, or a subsample with a rich battery of cognition.
So we've got a few more. It's not possible to take all these questions. I think I'll collect them and share them with you if you're interested. There's a lot of
Yes, very much so.
back to the idea of the expansion of disabilities by the younger cohorts and of those over 50. A question, is it because the US lifestyle, e.g. sedentary junk food, is it because they may have access to more services for people with disability? In other words, what explains, you said what descriptively is found in the data, but what are your hunches that could hopefully motivate future research in this area of disabilities and the differences in cohort and the differences between the stayers and the movers?
Yes, indeed. For us, the ability to preserve somebody's life, right, in the richer countries means that we're probably going to observe people living longer with the, say, if you hold constant the number of diseases or the number of disabilities, they're going to live longer. And so, but in this case, what we were comparing, yes, the stayers were compared just by the disability prevalence and not necessarily the life expectancy free of disability, right? If we were to compare the life expectancy free of disability between the stayers and the movers and the returners, maybe we would be able to adjust a little bit better for how disabled they are the rest of their lives. But yes, I think that the answer to the question is yes, the resources being spent in a country like the US in maintaining somebody alive means probably can explain why the stayers look more disabled.
And I think this will, here we go. Coming to an end, I want to say, I turn it now over to Dr. Simoni, Director of OBSSR, for closing remarks. And thank you very much, Dr. Wong.
Thank you, Mike, for all the questions and also to the audience.
Mike.
So sorry to have to cut this off. There were a lot of great questions and we can collect them and get them to you and maybe you can even respond. Thank you so much, Dr. Spittle, for organizing that discussion, Dr. Wong for spending the afternoon with us. I want to say that we will have a recording of this. It should be available in approximately 1 month. And with that, I will conclude the webinar. Thank you all for attending and have a great day.